Integrating with Facebook now. Good morning, everyone. Welcome. Feel free to introduce yourselves in the chat as you enter. My name is Chloe Edwards with Voices for Virginia's Children. Welcome to Racial Truth and Reconciliation Week.
All right, good morning, everyone. My name is Ali Faruk, and I'm the Policy Director for Families Forward Virginia, and we're so excited to have an
We're not quite like that, Ali.
Sorry, what was that?
We're not quite live yet.
Oh, okay.
I'll let you know when we're officially live. So I'm going through all the Zoom pages. Right, and we're live. Welcome everyone to Virginia's first ever Racial Truth and Reconciliation Week. My name is Chloe Edwards with Voices for Virginia's Children. I work on the campaign for a trauma-informed Virginia. This week is brought to you by Virginia's Trauma-Informed Community Network. Networks led by leaders of color. I also have a special announcement this morning. Virginia's Governor Northam has recognized this as Virginia's first Racial Truth and Reconciliation Week. You can read his proclamation up on social media. It'll come out to you soon and on our website. This is a historical moment, and I'm pleased to join our special guest today. I'm going to go ahead and hand off the mic to Ali Faruk with Families Forward Virginia, who will introduce our special guest today. Feel free to engage with us on social media and make sure you share this to get it widespread.
Good morning, everyone. My name is Ali Faruk, and I'm the Policy Director at Families Forward Virginia. We're so excited to have some amazing leaders, activists, advocates, and professionals to talk about this really important topic about basically improving health and well-being for moms and kids, parents and children all over the Commonwealth. This is not the beginning of this discussion, and it certainly won't be the end, but we do have a moment right now in our public discussion to talk about some of the very serious barriers that exist. So of course, Families Forward Virginia, we are a statewide nonprofit that provides home visiting services and child abuse prevention services using through 50 affiliates all over the Commonwealth. So we have amazing home visiting programs that have been working with moms and babies, parents and children for years. We start as early as prenatally all the way up to age 5 for many of the families that we serve. And we've seen and walked with parents through some of these barriers. But today we're partnered with Birth in Color RVA, which is an awesome group of service advocates. And we have some awesome professionals and leaders who are going to talk about this issue in more detail. So I'll hand it off to my colleague, Kenda Sutton-EL, who will talk more.
Good morning. I am Kenda Sutton-EL, one of the founders of Birth in Color RVA. We help pregnant people all over the state of Virginia during, before, and after labor. We advocate for them, specifically maternal and reproductive justice. We also have postpartum birth support groups for all parents. We educate, we teach nutrition. We have a wide array of services. So you can always reach out if you have any type of issues going on, or if it's something that a provider does not properly explain to you, you can always reach out to us and we'll provide you evidence-based information, and we'll also try to help you navigate throughout the system. So that's specifically what we have a wide range of services based around. And I will pass it off to my colleague, Senator McClellan.
Thank you, everybody. It's a pleasure to be here today for this important conversation. And I thought I would start, since we're sharing some of our issues around maternal health. I want to share my story because this is also Breastfeeding Awareness Week and Breastfeeding Awareness Month. And I wanted to focus some on how women of color sometimes have issues with breastfeeding that really go back to the foundings of this country and the founding of slavery, because so many women were forced, women of color, Black women in particular, as slaves who were forced to breastfeed other people's children. That created a little bit of a stigma based on just the trauma of that for women in the Black community. I remember my grandmother, who had 14 children between 1910 and 1932, breastfed all of them. But when my mother became a mother in 1960, right around the advent of formula, I think at the time it was condensed milk, she didn't want to breastfeed and did not breastfeed. I was the first member of my immediate family to breastfeed when I gave birth to my son, Jack, 10 years ago this Sunday. I was determined to nurse him, but I didn't really have a model. I didn't have a mentor. And while it is the most natural thing in the world, just like learning to walk or anything else we do, you don't always know what to do. And I had a class, but I had a very hard time getting started nursing and really nowhere to go until I happened to find a lactation consultant who could help me feel more comfortable, help me understand, you know, something as simple as the breast pump shields when I tried to pump didn't fit my breast. Like I never realized that they all come in different, you know, I knew they came in all different shapes and sizes, but I didn't realize that pumps are kind of one size fits all when you buy them at the store. And so I was able, with a lot of tears, a lot of support, to nurse Jack. Fast forward 5 years, I had a very high risk pregnancy with my daughter, Samantha. I had placenta previa, and that was something that almost killed her and me. When I woke up one morning, my placenta had ruptured and I started bleeding, and she was born by emergency C-section. And again, because I had access to prenatal care, I understood the risks and frankly got lucky that I recognized what was happening and we could immediately get to the hospital. And she was in the NICU for 6 weeks. And I was able to pump for her. But there were a lot of eye-opening experiences to me. I, as a member of the General Assembly, was able to work, you know, I was the first member of the House of Delegates to nurse while in office and pump while in office. And I had to force the House of Delegates to figure out a lactation policy for me. I had the privilege to be able to do that. And that informed me how important it is that you have institutional support, family support, personal support, just to get through your breastfeeding journey. And as a result, over time, because when my kids were born, we had very few supports in state law. We had none in state law. We had a few limited supports in federal law. So we were able to put in place in 2014, we passed a law requiring schools to have lactation policies for nursing teachers or employees and students, because I heard from so many teachers who, like me, didn't have support to continue nursing when they went back to work and to pump when they went back to work. So that required schools to have breaks, a private non-bathroom place for a mother to pump, and a safe place to store milk. We were able to get something very similar this year through the Pregnant Worker Fairness Act, which requires all employers to make reasonable accommodations, not only for pregnant workers, but for lactating workers. And so now employers have to provide breaks and a reasonable place, non-bathroom, for a worker to pump and a place to store her milk. We were able to pass a law in 2015, and I remember being pregnant when it was signed, that made it legal, made it clear that a mother can breastfeed in public anywhere where she's lawfully present, because so many women trying to nurse in an airport, in a public park, in the Capitol even, were shamed and told, well, this is indecent exposure, you can't do that. And it's like, well, no, actually, I have legal protections now. I can nurse wherever I'm legally present. we were able to do that because we had women, not very many at the time, there were 2 of us, who had recently nursed, but more now. Our experiences informed our policy. The stories of women we knew informed our policy. And so I just wanted to share all of that sort of on the nursing side, how important it is, because we know all of the benefits of nursing. And being able to expand and provide supports for women in general, but particularly women of color who are not often encouraged or given the support they need to nurse, is very important. And then now I want to turn it over to Delegate Lashrecse Aird, who will talk about some other ways that we have been able to support maternal health and outcomes for women of color to fight some of the disparities that we see.
Thank you so much, Senator McClellan, for sharing your personal testimony. And I want to thank the organizers of today's webinar for inviting me to participate. Senator McClellan has inspired me to sort of think all the way back to the lenses in which I see this issue, as well as, you know, how I arrive at trying to advocate for Black mothers, Black babies, Black families in the Commonwealth on this issue, and particularly during this historical week. I'd like to share a little bit about the lenses in which I see this issue, which for me began as a young mother. I had my first child my senior year in college on the way out the door, and my second child a little later. And I can remember being a young mother, young expecting woman rather, in a Black community trying to get support from physicians. And, you know, as I think back, I remember talking to doctors who thought that because I was in a Black community that perhaps I might have been less informed about what I was feeling, less informed about my own personal pain and or my birth journey, and having to go the extra mile to explain what I was feeling. And when I think about where we are today, and I remember my own experience, it's literally exactly why I'm at the table trying to fight for this issue, because even as I talk to mothers in today's day and age, this idea that their pain is not real, this idea that what they are experiencing is overlooked, it's still very prevalent, and it's very much unfortunate. And we have a long way to go and a lot of change that needs to be made to the underlying system to prevent this from continuing to go on. I think it's interesting to hear Senator McClellan talk about nursing, because while she was the first elected woman to have this need, I can remember being a staff person in the General Assembly and locking my door and trying to nurse and trying to pump while the session was going on, because that was the only opportunity to get a break. And so there are a lot of ways we need to change our system to support mothers. And I want to speak to a little bit about how I arrived to this conversation legislatively. So I'm carrying my own experiences with me as a young woman who, you know, started the motherhood journey very early. Well, not as early, but in my mid-20s. And when I began to ask the question around what Virginia was doing on maternal mortality issues, and then about, I think it was 2018, I started with the Virginia Department of Health. You know, some of the questions I was asking, some of the issues that I was raising, they were being talked about internally, but more in a bubble. And when I asked the question, what can legislators do? There were not a whole lot of recommendations. I remember at the end of a series of meetings, at the series of calls in 2018, it was December, saying, what can I do during the next legislative session to try and support the work you all are doing internally? And it was, well, just let us figure it out. We're working on it. But there were no formal recommendations. And when I think about where we are in 2020, we have come so far, but we still have so far to go. And I can recall it being January of 2019, talking to the Secretary of Health and Human Services saying, look, I think we need to try and work on this right now. I think we need to try and do something. And I was reminded, well, the governor is committed to this and we will do something, but maybe, you know, in a few years. And I'm just so grateful for leaders like you and advocates like you, because, oh, how things have changed rapidly. And this issue is at the forefront, and we're able to make incremental progress in just a little bit of time. So I want to talk a little bit about that progress. So we ended the 2019 session with $355,000 earmarked for the Virginia Neonatal Perinatal Collaborative, which is basically a group that works to ensure, you know, Virginia mothers have the best possible perinatal care. And that was like our first step to say, how can we figure out supports for the people who are already in the field doing this work? And that was like step number one. This past session, we made a number of changes, and, you know, Kenda, forgive me or jump in if I leave anything out, but I have to toot my own horn a little bit because I'm extremely proud of House Bill 687, which we finally were able to codify the definition for doulas as, you know, trained, community-based, non-medical professionals. And that really that bill did a number of things. It provided for a definition. It also established a registry. So when we talk about allowing more Black women, more women to have access to doulas and birth workers, there is a place that they can now go to actually find them in one digital setting. And then in addition to that, this really lays the foundation for the most important part, which is reimbursement. Now that we have this definition, the DMAS and state agency can now look at what should the reimbursement for doulas be, what services can be reimbursed, and like really trying to get at, if we are going to support women who are, you know, financially disadvantaged and or want to have access to doulas, how is the state really going to have financial buy-in to provide the actual dollars so that they can have access, which they should be entitled to in terms of necessary care. In addition to that, we just finished our first Maternal Mortality Awareness Month in July, which was very exciting because I think this shows how Virginia is trying to take an active role, because we have been pushing, because you have leaders like on this call in the legislature to say this issue is important to us and we have to continue to keep this conversation going and continue to look at how Virginia can provide as many resources as necessary to combat this problem. And I think, like, for me, going into the 2021 session and even the special session, it's going to be protecting money that has been set aside for additional resources in this pandemic that we will protect these dollars that are at risk now as a result of this pandemic that we set aside during this past budget cycle, so that we don't take steps backwards, because we saw that in the midst of COVID-19, our access issues in hospitals were really quite breathtaking. The fact that we know that doulas help protect our Black mothers, and in some hospitals they weren't being admitted, that just proves some of the systemic issues that continue to persist, but also that we can't afford to let the money that has been set aside for these mothers to go away. So I'm committed to this issue. I joined Senator McClellan in continuing to fight for these issues. We're going to be fighting really hard as we protect these dollars during the special session. And in 2021, we'll continue to look at policy measures that really will help really lay a new foundation in many of our systems that has allowed this issue to become what it is in Virginia today. And I look forward to the conversation, and I appreciate again being invited to participate.
Awesome. Thank you so much, Delegate Aird. I do want to pull in some of our guest speakers who work in the healthcare field as healthcare professionals. I want to introduce Dr. Blythe Bynum and Dr. Matt Schefft. So first, I'm going to tee up Dr. Bynum. She's a chief resident in the Department of Obstetrics and Gynecology at VCU. She got her BS from Duke and her MD from University of Mississippi, and served on the board of the Jackson Free Clinic and as education chair. Her research interests are in contraceptive attitudes in African-American population and in patients with substance use disorder. So I want to ask Dr. Bynum just to talk a little bit about her experiences and some of her thoughts.
I'd like to say, first of all, thank you for having me. I'm very glad to be involved in this conversation, and I think it's an important one to have and to continue to have going forward. I got into obstetrics and gynecology because of my love of taking care of women. Being from Mississippi, where the population of Black women is about 50% of the population, obviously, and being a Black woman myself, it's an obvious interest in me, and I think that I have a very special place within the hospital getting to take care of Black mothers, and it's something that I'm honored to do every day. I'm not oblivious to the fact that there is obvious racism within the medical system. I think that it is multifactorial. It is definitely a racial thing, it's a gendered thing, it's an environmental issue, it's an economic issue. But at the end of the day, I think it's conversations like this with the providers ourselves, with our representatives, and people that are really invested in this issue to come together and try and figure out how we can reduce Black maternal mortality and help make just our Black population healthier in general.
Awesome, thank you. So I also want to pull in Dr. Schefft because Dr. Bynum, you see a lot of patients, obviously, as women get pregnant and during the delivery. But another huge part of this process is, of course, after the baby's born, those first 6 months, those first few years can be so confusing. So I really want to pull in Dr. Schefft. He's an assistant professor of pediatrics at VC School of Medicine and practices at the Pediatric Hospital at the Children's Hospital of Richmond. So Dr. Schefft, I want to invite you to come in and just say a few words.
Sure. So yeah, again, thank you for having me. I will tell you that I am, out of everyone here, the least expert on the topic. But what I would say is that absolutely those disparities extend to pediatric care. You know, we are lucky to live in a state that has finally expanded Medicaid, which has improved access to care for families, including children. But that still remains a major issue. I think the other thing that I would like to say, sort of to call out, is that we just know that the medical profession looks too much like me and not enough like the rest of the panel, and that's a really big problem, especially in a city like Richmond, where less than half the city looks like me. So I would say that, and say that I certainly have stories that if it comes up, I can tell about sort of my failings in identifying my own privilege, but that's where we need to improve. One of the ways we need to improve our healthcare system.
Awesome. Can you two talk a little bit about, so I'll just throw out one discussion question. We've talked a little bit about, obviously it's really important for us. It's not just about individuals and parents and families. There is an institutional level of support that families need, because it does take a village. There's a community level of support. But talking specifically about the healthcare system. So Dr. Bynum, Dr. Schefft, you both mentioned, physicians, they tend to be a very white and male group. What are some things, aside from obviously trying to recruit more people and make that process easier, what are some of the things that need to happen in terms of culture change? Is it a conversation thing? Is it a one-on-one thing? I mean, what does the training look like? If a Black mom goes in and has a bad experience with a physician during, whether it's a prenatal checkup or postnatal, whatever it is, who's going to tell that doctor? Usually maybe the family and the mom isn't comfortable telling the doctor, hey, you're a rude a-hole. Who's there to tell the doctor, hey, is it the nurse? Maybe the nurse doesn't want to get yelled at. So, what does that system look like? How can that be changed?
I'm happy to speak on this a little. I think that, I've definitely encountered patients that don't feel comfortable coming to me as a physician or my colleagues with their concerns. And so I think that there are different places that the patients can go. I think, especially in labor and delivery, you have the opportunity to build rapport with your nursing staff. Although sometimes that can backfire if you don't get along with your nurse. I think that that is an opportunity to address patients' concerns about their care that they're getting. But I think one of the things that was spoken about before that Kenda can definitely speak on is the importance of having birth support system. So I think in my experience, doulas are a great opportunity for patients to have an advocate in the room with them, someone that isn't afraid to challenge authority or ask the questions, because especially on labor and delivery, when things happen very rapidly and things can become dangerous very quick, as Senator McClellan mentioned, it is difficult sometimes to explain to patients in the moment in emergency situations, and that's something that I think we should be better at as physicians, but sometimes there's not always time, and patients sometimes don't know what questions they should be asking. So I think that doulas and birth workers definitely could play a very important role in building trust between Black communities and the medical profession.
Yeah, and I would add, so as one of the things that I spend a lot of my time doing around the hospital is patient safety and improving quality of care. And one thing that we have known for 30 years now is that we don't blame the doctor or the nurse for the mistake that's made. We know that it's a problem with the system of care that we provide. And I think, so we have that framework, and so I think that is right for explaining to physicians and other healthcare professionals that, you know, the same is true. I think that a lot of times we don't see the difference in ourselves and our patients the way we should, but that understanding that there is a system issue, systemic racism that plays into that, that is not addressed, and that we need to find very concrete ways to think about that at the level of the interaction with your patient, right? Because I think we're, you know, I think it's up to folks like Senator McClellan to think about the big level policy issues, but tomorrow I'm seeing patients, right? And so, so understanding that exists, understanding those barriers, and then seeking, you know, solutions. So for example, I remember as a resident seeing a patient who was overweight, a young child, and saying, you know, I had read the book, I knew what you're supposed to do. We do counseling on, you know, healthy eating, on exercise, and all these other things. And so I walk into the room and explain all these things and basically just lecture to this family. And the mom looks at me, you know, just puzzled and says, well, you know, I live in a housing project. It is not safe for my child to go outside. How am I supposed to get an hour of exercise a day? And that hit me like a ton of bricks, because it was absolutely true. And so understanding that at the patient level, and then physicians, I think, also becoming advocates, you know, to work with our legislators are important as well.
Yeah, and
So I had the pleasure, oh, sorry, Ali.
Sorry, go ahead.
So what I had the pleasure of actually doing since the whole Black movement, a lot of providers are reaching out to me for the racial bias training. So like Matt said about not blaming the provider and the nurse, we're actually saying to blame the provider and the nurse when something happens, because a lot of them go by the book. Just like you said, you had read all this book, but when you have all that book knowledge, we tend to forget common sense to say, okay, wait a minute, let's think of a common sense situation, because I can apply common sense to this to get a more healthier outcome. So after, you know, training with these providers and explaining things to them, and they tend to think over the top. Like on one training call, I asked the question, do all Black people have underlying conditions? A person answered yes. And I said, okay, so let's back all the way up. And they had to realize, like, my books actually taught me this. So that's why I said that. Not realizing common sense is half of the people who wrote these medical books were still under a systemic racism issue. So we have to redesign the whole entire healthcare system, starting with medical school, because medical school gets you to think more races than sometimes you end up thinking more races than before you even went to medical school. Because these books are telling you, well, with this type of person, you have this issue. Oh, when a Black woman comes in, she can deal with a lot of pain. So when she's in pain, she's just whining about the situation. So these are things that I had to bring awareness to them. And they had to realize, like, you know what, that is very true. And so I had one person who said, so I'm going to walk into the room and I'm going to say, I had all this diversity training and I'm really, really good. And if I want you to tell me if I have an issue. I said, wait a minute. No, we're not going to do that, because the goal is to build trust with your client. And they're going to look at you like, okay, so you're talking to me this nice and telling me that you did this diversity training because you are getting looked at for this specific reason. And then they had to be like, you know what? I have to use common sense. That is a really, really good tool, because we forget that common sense can help a lot of these issues. Like if a mom asks you, well, I don't really understand that. It could be because she was never properly educated on that. Did you ask her what her grade level was, or did you even look at the application when she comes to your office? A lot of times physicians get passed a folder, but they don't look all the way at the very, very beginning where it says level of education, all of these other things that can actually help you better assess the situations. And so that's why we are proposing that patient navigators actually get in place to say, okay, these are the people who don't specifically work for the provider's office, but don't have a problem with telling a provider, you were wrong in this instance, and this is why this outcome could have happened. Because I had case studies that I present during the racial bias trainings that gets them to look at certain situations like, oh, we could have saved this mom, but she didn't feel comfortable. She didn't feel like she was being listened to. So therefore, she didn't even tell us her whole life history, which you could have got that blood clots running her history, anemia running to her history. So her clotting out and passing away and the baby not making it and she not making it, all of these things could have been resolved with simple conversations. So that's the best tool, is to like actually have conversations with your patients and your providers, because this will help you make a conscious decision on, okay, this is how we can effectively help. And even though, like Senator McClellan was talking about the breastfeeding, I cannot wait for Black Breastfeeding Week, which starts August 25th, because we have designed a new tool that we have realized that in the state of Virginia, that we do have we have came a long way with breastfeeding, but there are simple places that should have breastfeeding places that do not have them, that are state owned. So I cannot wait to like bring all of the information and capture the pictures so that we can show that, okay, when we say these things, we aren't just making them up. We aren't just saying, well, this is happening, because I know during the legislative session, like I was there advocating, talking to the different delegates and senators, like, hey, can you do this bill? Can you do this? These are me and Ali, like we had a whole system of what we were trying to get done. And they were just like, oh my God, these people, they're just like, keep nagging us. But we had crazy questions that people were asking us, like, oh, so you can't just pull out the boob and like breastfeed, and like certain things that it was just like, are you serious? In 2019, you're still asking these questions. And the amount of senators and delegates that still don't understand that certain things still exist, and unless we have a policy for them, they're never going to change. And this is why we also need not just advocates in General Assembly, we need providers in General Assembly, because you guys can actually help us to get these policies that you see on a day-to-day basis into effect, because the senators and politicians are actually going to listen to your professional opinion. Because when they look at an advocate, okay, they're an advocate, they're advocating for this, not really understanding what my knowledge is. But when they see a provider, they're like, oh, that's a provider. They have a lot of experience with this. So these are the things that we're asking. Like when we don't just end the conversation here, like think of ways that we can actually make some real changes in Virginia.
So I want to add a couple of things to that. So I'll give you a specific example of some of the crazy questions that we get. So with the school lactation bill, I remember being in a subcommittee and hearing, I think it was the senator at the time, say, well, why can't the teacher just wait until her lunch break? And I very deliberately said, okay, well, she's probably been at the school since 6 to 7 a.m. Her lunch break, if she's lucky, is maybe 11 or noon. Here's what happens physically when your breasts get engorged. And I started to describe it, and then all of a sudden it was like, oh, okay, never mind. Yeah, okay, I get it. But it's like, well, why can't she just train her breasts? Well, what's wrong with going into the bathroom? I'm like, well, you wouldn't eat in the bathroom. Why would you expect someone to prepare their baby's meal in the bathroom if you're not willing to eat in the bathroom? We had this year with the Pregnant Worker Fairness Bill, some senators who view things through their own life experience. Well, I have my employee, I give her a place to pump. Yeah, I take care of her. So why do we need a state law? It's like, well, because there are a lot of employers who don't. There are a lot of employers who don't even think about it until they're forced to think about it. And by then is not the time to develop the policy. And then one other thing I want to add, because we haven't touched on, I think Matt alluded to it a little bit, by dealing with what happens in the first few months or year. That's when a lot of Black women die, is within the first year of delivery. And we know their comorbidities could be, cardiovascular. Many die of heart attacks. We know our bodies. And when we know something is wrong and we show up at the doctor's office and we say something is wrong, sometimes the doctor looks at our folder and says, no. So I met a woman who had her first heart attack at 36 after she had her first child. She knew she was having a heart attack. She went to the doctor and the doctor looked at her and said, you don't present any of the risk factors for somebody having a heart attack. And he sent her home. She not only had a heart attack, she ended up having to have a heart transplant and almost died because that doctor just looked at her chart and didn't listen to her. And I think part of the institutional change we need to make goes back to what some people are taught in medical school and combining that with what a piece of paper says, and not just taking the time, let me listen to my patient and what my patient is saying, because she knows her body better than I do.
And if I can just put a fine point on both what Kenda and Senator McClellan have stated, I remember speaking to a physician who was in the General Assembly when we first began having these conversations. And I went to him and asked him to describe what recommendations he would offer to get to sort of the medical school training level of this problem. And he basically saw no need to change anything that was in place. He could not grasp his mind around the idea that we would want to add things like additional implicit bias training, I mean, anything. And so when you talk about the need for advocacy, both from, leaders and like people, providers, these actual stories of what families and women have actually gone through are so critical. And it's hard to feel like you have to be on record with leaders who are in a decision-making capacity about your own personal reproductive health and or your own birth story. But it's so critical because for some of these people, it's totally unfathomable and it's out of sight and out of mind. The last point I will make is when we were talking about how to get this money to have additional resources for some of the tools we're talking about, you literally had budgeteers, the people who write the budget, who thought that maternal health was about abortion. And they asked, well, why are you trying to get this money when, you as a Democrat, you are all for pro-choice and you are, trying to not save babies. I mean, this is the gap in understanding that literally exists among policymakers. And I left that room thinking, oh my goodness, this work is going to be much harder than I imagined. And so I just want to put a fine point on the people who are in positions of power, their lack of understanding, and the critical need to continue to not have conversations like this just among ourselves, but also like very publicly and talking to your representatives about why this is critical and sharing your own personal testimony and story.
Yeah, that is so critical. And one thing You know, we've talked a lot about how folks like Delegate Aird and Senator McClellan have expanded access to services, expanded protections, but a huge part of this is trust. And so you can give some of the amazing programs, you know, the Medicaid program, Famous Moms and things like that. But mom goes to a doctor's office and she doesn't trust the provider, she doesn't feel heard. Telling them your health background, your health risks, maybe the other things in your life, that's intimate stuff. And if you don't have trust in your provider, you're not going to do that. And so that's where, you know, Kenda talked about it a little bit, where birth workers and doulas, and for our network, we have a lot of home visitors, and we have home visitors that are watching this, this broadcast right now, awesome people at programs all over the state. They walk through that journey with the mom. You know, they're often, I've heard so many stories from home visitors that say, every time I visit, I make sure to ask him, what was your doctor's visit like? What did they say? Did you tell them about this? And did you tell them about that? And what did they say? Did they hear you? Do you feel heard? And often they help them bust those barriers. Sometimes it's finding a different doctor. Sometimes it's saying, hey, look, when you go to that doctor, this is exactly what you're going to tell them. And don't leave that room. And another part of it, and I'll make this point, and then I'll invite Dr. Schefft and Dr. Bynum to comment on the trust issue a little bit, is that when you have a person talking about their health to a healthcare provider, and that healthcare provider, you know, has a preconceived notion in their head of the person in front of them, that's more than just a barrier. That you're not going to dispel that barrier just by talking to that person. You know, that's like Delegate Aird and Senator McClellan said, you know, having these conversations with people in power, and like they can't wrap their head around it. And for us, it makes sense. It should be common sense, right? This is a baby. You're talking about taking care of a baby. Doesn't everyone want that? But it's more than just having individual conversations. We really need to be talking about structurally the way healthcare providers are trained, but also where's some of the accountability? And that's what I want to invite Dr. Bynum, Dr. Schefft to talk a little bit about. How do we get to a system that is more accountable, so that when this problem does pop up, because people are imperfect, we're not saying people are evil, when that problem does pop up, how can we get to a place where it's caught quickly and we're able to catch it?
I'll try to speak to maybe the accountability part. Although I'll preface by saying I don't have a good answer. But I think some of it goes back to empowerment, like a lot of the speakers have said, right? And I think that's at all levels. So I think it is important, one, that if it's my clinic we're talking about, that anyone who sees me acting in a way that is not patient-centered, and that specific patient-centered, should be able to call me on that. And creating a culture that allows for that is really, really important. And I don't care whether that's someone who works at the front staff, if that's a nurse, if that's the patient themselves, right? And advocating for any one of those people to say, hey, like, I don't think you're really hearing me. And then you know, it's incumbent upon me to hear them say that, right? And you know, as we get to a place where, you know, me or you know, other physicians are better at having those conversations, because I saw a comment in the chat about how it is not the patient's responsibility to teach me about systemic racism. Like that's something that has to happen institutionally within us, within our organization. So I think that there's a piece of it that is the culture, and then the accountability part where we have a system where those things can be reported, and training and education, you know, and frankly, if it needs to happen, discipline occur.
Dr. Bynum, are you still with us?
Yeah, I am. I agree with Dr. Schefft. I think that definitely making sure that within our practices that everyone that we work with holds us accountable, and make sure that we're always practicing patient-centered evidence-based medicine, because I think that if as long as we keep that at the center of our practice, that's what will keep us moving forward and give us the best care for our patients. I think that in addition to that, it is difficult to find a solution within the medical system the way it is currently, because it's such a hierarchy, and it isn't a community that looks like me. It is a lot of white men. And I think that one thing in order to go forward would be to hopefully change the face of medicine. And I think that that often starts from top down. And so I think that that is something important that each hospital system or medical system should be looking at, because when there's no one in leadership to help guide these types of decisions, it's very difficult to make changes within the system itself.
Yeah, and one thing I'll just mention and invite other people to talk more about, and this is something we've experienced when we work with families. If you have people who are acutely aware, you know, Black moms, Black families that are acutely aware that this system is racist, that they're not going to be taken seriously, that they have to be on guard, they're probably not going to, you know, they're not going to challenge the authority. They're probably, you know, I've had Black moms tell me that they do teach their children to be deferential to authority. So then it's not really fair to expect that suddenly in a doctor's office, they're going to be like super aggressive and asking a lot of questions and giving accountability. So part of that care, I think, really does need to be this aware of systemic racism.
Yeah, and I think it's really important to understand, especially for first-time mothers, you don't know the right questions to ask. You know, I remember being completely clueless about what to expect, and even reading the books. First of all, you know, everybody immediately goes to what to expect when you're expecting. The front cover doesn't reflect how everyone looks. And even when you read that, you're just like, it doesn't really give you a clear picture of what to expect, especially postpartum. And I think the most confusing time for me was both times, postpartum, because there were very different pregnancies, and just the feeling of, is what I'm feeling normal, or is what I'm feeling something I should be worried about? And if you are a marginalized woman who doesn't trust your healthcare provider to begin with, and you don't know what questions to ask, and you don't have family support or community support, and you don't have a book you can clearly read, you're lost. And so making sure, I think, that we are providing community supports, and again, that's why doulas are important. But even beyond doulas, we just need community supports. Even the classes that you take at the hospital can be inaccessible for a lot of people, to help them understand, here's what to truly expect in plain language you can understand, of here's what's going to happen to you, especially postpartum. Because I made it a point when I was on maternity leave with Jack, my oldest, every friend I had who told me they were pregnant, I would say in great detail, okay, here's what you're not gonna learn in the book. Here's what they don't show on television. Because on television, women give birth and then immediately they look the same and they're back at work, and you know, it's as if nothing ever happened. And none of that is real. And so we've got to demystify pregnancy and postpartum for all women in all walks of life.
I definitely agree with Senator McClellan, especially as far as postpartum and breastfeeding. On TV, it is like, oh, I can just put a pump on it and milk will flow. Oh, I can just put my baby to my nipple and milk will flow. That is not how breastfeeding is. Breastfeeding is extremely difficult. You cry, you get depressed, you feel like, oh my gosh, I can't do this because I don't understand. So a lot of the time with my clients, I spend a lot of time on postpartum and breastfeeding. Like I probably spend at least 6-7 weeks, hours of just showing them and explaining to them, like, this is going to be difficult, but we will definitely get through it. And that's where that support comes in. And that's where the trust comes in. Because I've had just recently, like my OBs, they know, like, okay, she's not going to ask a question if she doesn't feel like it's necessary. So I will text a provider and say, hey, this is what's going on. We are at the hospital. You are not on call, but this is the situation. and they will actually get on the phone with me, go to speaker, and say, this is what's going on. And this is, and I don't expect all providers to do this. These are providers who really know what's happening in these hospitals. And so, and that helps, that level helps to calm a patient. Those double backs, those checkups, and explaining, like during postpartum, this is what's going to happen. These are signs that you need to look for. And even though the providers aren't explaining it to them, and this is where classes and community support and why community advocates and things like that should be funded, because we take a lot of that risk and a lot of that educational piece to make sure that they properly have systems in place. We talk about making sure that you have family in place, making sure that you have meal trains, because if you are breastfeeding, you have to eat if you want to have a healthy milk supply. And these are things that aren't just talked about. And a lot of people, first-time moms, have no clue what to ask. They go to the doctor. They're like, well, the doctor told me that, so I'm just gonna go with it. Not realizing the doctor told you that, and that was for another patient. Like, they didn't go by you individually. And so that actually matters, because I want you to, it's just like weight loss. It's no one-stop shop for weight loss. Everybody is individual. And that's what we need providers to understand. In maternal care and infant care, they're all different. And I don't want you to look at me like, okay, well, I had a patient that was similar to this, and I want you to look at me for my issues, what's going on with me, what I'm explaining to you that is actually happening. That actually is going to matter, and it matters life or death. And if I'm going to get through this, and that's why I was glad that ACOG actually now looks at fourth trimester, because that fourth trimester is extremely difficult. And I know that, I think we expanded, Medicaid did expand to the 1 year coverage, but they need more than that, because sometimes issues don't really rise until fourth month. And then it keeps going and it keeps going. And until all those issues are actually looked at, like what's going on with me. I have a girl, she's 115 pounds. She had gestational diabetes. She was 6 months postpartum and she still had the diabetes issues. They threw her straight to insulin, not actually looking at what's happening internally to her body. We're just gonna throw you straight on insulin and figure it out the rest later. And never followed up, never went back to say, okay, well, how are you eating? What's going on with your nutrition? Let's actually look at the internal side of your body. Referrals, we know that endocrinologists study the internal side of the body. So why aren't they using the system the way that they should, the specialties? Like, refer them out if you don't understand or if you don't want to deal with it. And these are things that providers aren't really using the tools that they actually have also. I'm not sure how you providers feel about that, but have you noticed that, okay, they don't want to refer, or they're not using all of the tools that they actually have?
I can speak on that a little bit. I think from my perspective, at the hospital that I am, it hasn't been the case that the Medicaid was expanded past the 6 weeks postpartum. And so in that sense, it has been very difficult for us to get patients linked up with providers. And I think, unfortunately, being at a hospital that is a catchment for the region, a hospital that sometimes is the only one to accept certain types of insurance or take care of the uninsured, the wait list for specialties like endocrinology, cardiology, ophthalmology, all the important things that women need postpartum is ridiculously long. And unfortunately, that's just an issue with the healthcare system. There's just not enough doctors, not enough providers that are willing to take care of these patients in this setting. And so I think that it is definitely an unfortunate issue. And I think that the expansion will greatly help it, but I think that more providers is also something that can also help this issue.
Yeah, there's definitely some perverse like reimbursement incentives around that really don't do any favors, right? That incentivize doctors to move on to that next patient and not take each individual patient seriously, which is a really major problem that I know there are a lot of good people that are working on. But I think, Kenda, I think that you're also right that that a lot of times we are not aware of what we're capable of in terms of bringing resources and education and help to the patients that we're seeing. And that is a problem. I think that, and part of the problem too is that, you know, like Dr. Bynum mentioned, I think a lot of the patients at a place, you know, that at an catchment hospital like ours, you know, they do get pushed to the resident clinics that have the fewest resources. And that's a major, let's call it racist issue in the way we care for patients. So I think you are right that there's more we could be doing, and it doesn't help certainly in the way the system is set up.
Yeah, well, we're getting near the end, and I don't want to cut off this conversation because, you know, like I said, this isn't the beginning of this conversation and it's not the end. So we intend to keep advocating and talking about this issue, but I did want to wrap up because there are a couple of questions about policies. So there were a lot of really great things this past session that were funded, but unfortunately then they had to kind of become unallotted. One of those was the extension of Medicaid postpartum from 6 weeks up to a year postpartum. Unfortunately, the funding for that was unallotted. There's also an expansion of home visiting services throughout the Commonwealth. That was going to become a Medicaid service that was also unallotted. You know, home visiting, we are one of those services, just like doulas and others, where we're seeing those social determinants of health. We're seeing those things that affect the mom's health and the baby's health because we're in the homes with them, we're talking to them, we have that relationship. We're serving just under 10,000 families across the Commonwealth, so we're able to have amazing outcomes when we're there helping the families, but we're not able to reach all families, and unfortunately that funding was unallotted. But there will be some budget changes, so I guess I'll throw it to Delegate Aird and Senator McClellan if you want to say a few words about the upcoming budget session. We don't really know for sure what's going to happen, but August 18th, the General Assembly will come back in session. Perhaps some of those will get funded, perhaps it won't, we don't know. But what we do know is that we're going to continue advocating and continue talking about, you know, I do want us to keep talking about what are the culture changes we need to make among physicians and healthcare providers and hospitals? What are those accountability measures we need to put in? What are more community supports that we could be providing, whether it's home visiting or doulas? And also from Senator McClellan's and Delegate Aird's awesome work, what are the continuing protections and things we need to give so that families can continue to provide the care that their children need? Kenda, any final words, or Senator McClellan, Delegate Aird, anything you want to say about the session?
I was going to say, you threw a lot in there at the end, and I didn't know which piece to take first, but I'll just speak towards the legislative session. So as you stated, yes, we'll go back into special session on August the 18th, and there will actually be a budget briefing on that morning prior to us going into session, which will speak to many of these questions. From what's been shared with me and Senator McClellan, let me know if you've heard something differently. I expect the process regarding budget deliberations to sort of reassess those unallotted dollars to probably take some time and possibly carry out well into September. They are looking at the most recent budget projections and shortfalls that have been widely reported at this time, and the way new dollars have been expended to determine, can we afford to primarily keep all of those efforts we had taken during the original budget cycle during the 2020 session. And so that's not the answer you're probably looking for, but the short version is that they're very much still under discussion. And I know that I joined Senator McClellan in continuing to talk with budget leaders to advocate for the money that had been allocated for some of these resources that we've been talking about today. And so trust that you do have an advocate at the table that are trying to fight to make those dollars a reality.
Yeah, I would echo that and just reemphasize that with Delegate Aird on the Appropriations Committee and me in the House and me on the Senate Finance Committee, we're on the subcommittees that address these issues. We're both on the Joint Commission on Healthcare, so we will definitely be at the table and very vocal on these issues. The last thing I want to just connect, going back to the institutional and community supports, we cannot ignore the impact on the workplace on pregnancy and pregnant outcomes, and we need more family-friendly policies like paid family medical leave, you know, like the Pregnant Worker Fairness Act that we just got passed and need to make sure are implemented the way we intend them to. making sure that predominantly Black women who are in low wage jobs that don't have the protections and the supports they need when they become mothers is something we are critically focused on, because we cannot just fix this through healthcare policy. It has to be holistic across all the issues we deal with that just center mothers and families and children, and recognize that mothers are in the workplace and not just sitting at home.
And if I can just add one additional thing as we're closing, I just want to say thank you again, because I tried to state this in the chat, but the more we can create space intentionally for these conversations, formally like this, via a webinar, or even just within our own circles, I think that's going to be critical to advancing this conversation. We need to get to a place where it's not uncomfortable, this idea of building trust, as been mentioned many times during this conversation. We need to get to a place where there's not discomfort in talking about the very realistic statistics of how Black women are being impacted, and being able to say racism without someone sort of getting offended or feeling defensive or feeling uncomfortable, making this a normal part of the work that we are doing and part of healthcare policy. That's critical. But then just as a Black mother, knowing that there's a space in my community where I can talk to another Black mother, I can talk to another expert who has experienced what I might be experiencing, or can tell me, hey, this is what I did, maybe this might work for you. Continuing to be deliberate about that work, I think is just going to be key all around to combating some of these barriers. So thank you.
Delegate Aird stole my speech, so I was actually going to say those same exact things. If any moms are watching, or anybody who has mothers that are watching, they can always reach out to us and we can help as much as we can. birthandcolorrva@gmail.com or birthandcolorrva.org. Also, special sessions coming up. I'm going to try to push to say, because we don't know what the pandemic is going to look like and when it's going to be fixed or anything like that. So when flu season comes and wintertime season comes, we don't want other areas to backtrack and not allow doulas again. So I'm gonna try to push that we have something legislatively to make sure that doulas are allowed in hospitals separate from the one support person. That's all.
All right, well, thank you all so much. I really appreciate everyone being on here, and I will conclude by passing it back off to my colleague, Chloe Edwards from Voices for Virginia's Children, who helped us organize this and who is leading the Racial Truth and Reconciliation Week, where they've had so many amazing events. Chloe?
Thank you. Thank you, everyone, for this great session and helpful conversation. I do want to iterate that the Governor of Virginia historically recognized Virginia's first ever Racial Truth and Reconciliation Week. Social progress occurs when every Virginian stands alongside one who experiences an injustice. You can visit vakids.org to see our lineup and events today. We will see Senator McClellan a little later today at 4 p.m. for our Q&A with the Virginia Legislative Black Caucus. And I also encourage everyone to attend the governor's statewide town hall on racial equity and police reform, where he will recognize Racial Truth and Reconciliation Virginia. Thanks, everyone. I envision a world where this isn't just another conversation, but instead racism is an institutional intolerance. Thank you for being a part of moving Virginia forward.